Hi there. Over the course of the last number of lectures, I've talked to you in great detail about mechanical ventilation. Usually the indications for it, mechanics behind it, the physiology that impacts on it, some important formulas that we've covered. But what we haven't talked about yet is how to get somebody off mechanical ventilation. We've spent a lot of time talking about how to put somebody on one. Now we should talk about at the end of the line, getting the patient liberated from mechanical ventilation. We know that mechanical ventilation is life-saving, but we also know that patients spend way too much time on it. And we also know that prolonged ventilation is quite risky. There are a number of risks associated with being on mechanical ventilation. And starting with the endotracheal tube, you can see that there are a number of problems from the tube itself, from things as simple as malpositioning to increasing the risk of developing pneumonias, as well as aspirations, both micro and macro aspirations can all occur. Inappropriately placed endotracheal tube can lead to mucus plugging to develop, both because of the patient's unable to adequately cough, and also if the tube is positioned in a way that the suction catheter only goes preferentially down one lung, you may end up only suctioning one of the lungs. And then finally, there are injuries directly to the larynx and also to the trachea, causing erosions, and then downstream, increasing the risk of developing subglottic stenosis. The ventilator is also not without its consequences. Ventilator-induced lung injury is an important cause of ongoing damage, in addition to diffuse alveolar damage that can occur by being on mechanical ventilation. Being immobile as a result of being on mechanical ventilation can lead to the development of ventilator-induced diaphragmatic dysfunction and also atelectasis if they're not being properly mobilized to get dependent regions of the lung mobilized and recruited. And then finally, inappropriately set ventilation strategies, especially in patients who have low compliance, are at higher risk for developing pneumothoraces. Other organs are also at risk for developing complications from mechanical ventilation. GI bleeds are much more frequent in critically ill patients on mechanical ventilation. Salt and water retention can occur, and it's not just the consequences of us giving them lots of fluid during resuscitation. The production of renin, angiotensin, and aldosterone all also lead to salt and water retention. Now, fortunately, malnutrition is much less of a problem in patients who are on mechanical ventilation these days, as we're much more sensitive to the nutritional needs of these patients and starting tube feeds a lot sooner. But being immobile can lead to an increased risk in deep vein thrombosis, and being tied down and given a lot of heavy sedation, in addition to being critically ill, can lead to delirium and subsequently also in developing polyneuropathy and polymyopathy. So the question really now is, what is the best way to wean somebody from mechanical ventilation? And to be clear, weaning is defined as that process of gradually increasing respiratory muscle work for training. And when we were trying to study and find the best and most effective ways to wean somebody from mechanical ventilation, there were a number of studies that were performed at the end of the 1990s and early 2000s, which were pinnacle in changing the mindset and the way in which we approach patients who are on mechanical ventilation. These studies were sought to find what was the best way to wean somebody from mechanical ventilation, and they used a variety of different techniques. And the goal was to find out which of those techniques was the best way to wean somebody from mechanical ventilation. But as part of the protocol, they required that the patient first perform a readiness to breathe trial first. And if they completed that trial, then they were excluded from the study and were actually just extubated. Now, what we found was that 76% of the patients who completed the readiness to breathe trial were actually ready to breathe, were extubated, and they didn't require weaning, they were just extubated. And so this means a number of things. Number one, the majority of patients that we deem ready to wean are actually just ready to be extubated after you give them a brief trial. Second, in all of these studies, we found that SIMV is a terrible way to wean somebody from mechanical ventilation. So just don't do it. And third, and probably most dishearteningly, physicians are terrible at guessing off the top who is ready to be extubated. So there has to be a better way of doing this. Because what we're trying to do is expedite liberation from mechanical ventilation. And so there are a number of steps we can go through. Step one, probably the obvious. Number one, treat the underlying cause. If they have pneumonia, give them antibiotics. If they have acute lung injury, reduce the inflammation, give them some time, treat them gently, yada, yada, yada. A lot of the problems that lead to mechanical ventilation are due to a problem of misbalancing between increasing respiratory load and a decreasing strength or drive to breathe. And so if you approach your patient you're trying to determine whether they're ready to be extubated and answer the question, do they have increased load? Do they have decreased strength? Do they have decreased drive? How can I reset this balance? It'll go a long ways in treating their underlying cause. Second thing to do is prevent iatrogenesis, and this occurs long before the patient's even ready to be considered for extubation. In order to prevent iatrogenesis, a lot of what you have to do is a lot of what we've already talked about in terms of the risks of complication of mechanical ventilation. You should focus on reducing the risk of ventilator-induced lung injury, use bundles of protocols in order to prevent ventilator-associated pneumonia, make sure patients are on appropriate GI prophylaxis, either using pharmacological agents or by initiating tube feeds, whatever your local culture and beliefs of the week happen to be. There is a significant amount of diaphragmatic dysfunction that occurs from mechanical ventilation, and you need to work hard to prevent that. Also preventing the consequences of polyneuropathy and polymyopathy of critical illness. Patients who are fluid overloaded during the resuscitative phase need to have that corrected before you can expect somebody to be ready for extubation, and also reducing the amount of sedation that they're getting. Probably the number one thing you can do to speed up the patient's readiness for extubation is to reduce the amount of sedation that they're getting. By cutting down on their sedation overall, and also by performing daily awakening trials, you can significantly decrease the amount of time somebody spends on mechanical ventilation. The final step is to have a process in place that will help you recognize people who are ready to breathe on their own and be extubated. And this is what we call the spontaneous breathing trial. Performing a spontaneous breathing trial starts on a daily basis, either by the physician or can even be performed by a respiratory therapist. The daily assessment answers a number of very simple questions. First, is the patient hemodynamically stable? Doesn't mean that they have to be off vasopressors. It just means that they have to be on low levels and decreasing doses. Second, is there any evidence of ongoing acute lung injury? And is the PF ratio greater than 120? And finally, do they have sufficient oxygenation, such as that they only require a PEEP of 6 or less in order to maintain normal oxygen saturations? In those cases, when the patient has met those criteria, they should then be moved to the next step of a spontaneous breathing trial. To do this, you simply place the patient on a spontaneous mode of ventilation, as a pressure support mode, with a pressure support of less than 7. Or if you would like, you can even just place the patient on a CPAP mode with a support level of only 5. Now, you do this for a half an hour or up to 2 hours. The original studies that outlined the spontaneous breathing trial used a 2-hour time limit, but subsequent studies have shown that you only need to wait for a half an hour before you can accurately determine whether somebody is ready to be extubated. What you're looking for is the response to the spontaneous breathing trial. They need to have a respiratory rate of less than 35, They can't become tachypnic as a result, and they cannot develop any hypotension, and their arterial blood gas has to remain normal or normal for them. Failing this, you need to look for causes for the failure. They have, if the cause for their failure was rapid breathing or a rising CO2, then this is the problem of increased load or decreased capacity. If hypoxemia was the underlying problem, then secretion control, atelectasis, and pulmonary edema are much more likely to be the reason for the failure. Now, at this point in time, the patient has demonstrated that they don't need the ventilator. The question now becomes, does he need the airway? And so, in order to answer this question, you need to then decide whether or not their secretions are manageable. And we do this by a number of different methods. First, by checking for a cuff leak. Second, by checking their cough peak flow. And a peak flow of greater than 60 liters per minute is associated with a strong cough. Patients who are suctioning more frequently than every 2 hours probably have way too much secretions and will not be able to manage their secretions on their own. And then finally, they need to be conscious enough in order to protect their airway. If they fail this, then the cause of the failure at this point in time is that they usually have a weak cough, they have far too much secretions, or they've developed upper airway edema as the reason for the lack of their cuff leak. But if they pass that or they meet all of those criteria, then it's time to be extubated. So what do we do about those patients who fail the spontaneous breathing trial? There are usually a number of reasons for it. There are both pulmonary reasons for their failure, and at the core of this, as we've talked about, it's usually related to some form of imbalance between load and capacity. Diaphragmatic dysfunction, it can be also caused by a variety of different things and is usually marked by the presence of a polyneuropathy or a polymyopathy of critical illness. And then finally, look for other causes such as increased resistance or decreased compliance as the reason for the increased load on the respiratory system. Now, hypoxemia can also come from both pulmonary or from cardiac causes. Pulmonary causes are, again, usually associated with secretion management, but cardiac causes can be related to the development of pulmonary edema. And even if the patient's primary problem was not cardiac in nature, just the increased workload and the increased oxygen demand as a result of this workload may be sufficient for the for the heart to start to develop low-level failure and to develop pulmonary edema. So you have to watch out for that as well. Now, if the patient fails, well, it was a good try, and you just simply put the patient back on the ventilator, and you can try again tomorrow. But if you find that neuromuscular weakness is a central problem, then you're probably going to need some form of a formal strength building program in order to get this patient liberated from mechanical ventilation. And in this circumstance, you probably will need a tracheostomy in order to make this happen. Now, the process of strength building with the diaphragm is really no different than the process of strength building when you're doing exercises in a gym. You just begin a program of gradually increasing the amount of load over an increasing period of time until the patient gets to a point where they're completely liberated from the ventilator. So as you can see here, the patient needs to go through a process of gradually increasing steps, of gradually increasing time off of the ventilator. You start with a very low amount of only 30 minutes and then increase it by another 30 minutes to a full hour. You then go through this gradual process of increasing the amount of time they're off the ventilator until they're completely liberated. Now, it doesn't matter whether you have this process in these steps in this manner, or if you use your own, you have your own approach. The most important part of this is that it is progressive, building strength, and is also consistent so that the patient and the staff know what to expect. In those cases where the patient fails on a certain step, say they become tachypnic after 3 hours into a 4-hour spontaneous breathing trial, then you have to stop and put them back on the ventilator and give them some rest. But you also then should take 2 steps back the next day and start again. Now, sometimes there are times when you need to break the rules. If the tube has got a lot of secretions built up and it's really thick, then the increased resistance in the airway is not the patient's fault, and it's probably more load than they can actually build on their own, and they probably will be better off with that by decreasing the resistance by just simply taking the endotracheal tube out. There are also some patients who become extraordinarily bronchospastic anytime they're awake and they're on the ventilator. And in those patients, it doesn't matter what you do, you're just never going to get them comfortable and not tachypnic when they're on the ventilator. And you have to just eventually take the bull by the horns and just take the tube out. Particularly in patients who are head injured, we'll see often that they get very anxious and become very agitated when they're on mechanical ventilation. And because the problem in a head injured patient doesn't usually lie with the lungs, we find that once the patient's awake enough and able to protect their airway, if anxiety and agitation is causing problems with failure to wean from ventilation, sometimes the right thing to do is just take the tube out and let them breathe on their own. And then there's also the patients that you have to remember will always breathe rapid and shallow. It doesn't matter what you do with them. So the patient with interstitial lung diseases, they're never going to breathe 12 times a minute. They haven't done that in years, so don't even worry about that. If they're breathing the pattern that they breathe normally on the ventilator, then they're probably good to go. The last population that you need to always remember, though, are the patients who have COPD. If somebody was intubated as a result of an acute exacerbation of their COPD, and you've treated the underlying infection, and they're now in the process of weaning from mechanical ventilation, you might want to consider putting them on non-invasive ventilation as a bridge to getting them off mechanical ventilation. We've found in many clinical trials that extubating to BiPAP in that patient population reduces the total amount of time that they spend on mechanical ventilation and decreases the risk of complications. And the process is fairly simple. Once they're better, once they're on the recovery phase of their illness, you got them onto a mode of ventilation that you can easily mimic on non-invasive ventilation, extubate them, put them on BiPAP, and then just start weaning them from there. Patients who are on mechanical ventilation suffer. They are uncomfortable, they're anxious, they're in pain, and recognizing those things will help you reduce the amount of suffering that patients are caused when they're on mechanical ventilation. Decreasing the amount of time they're on the ventilator will also decrease the amount of suffering that you're causing. And having an organized approach to mechanical ventilation and liberation from mechanical ventilation will save you both time and stress and also improve your patient's outcomes. Thank you for listening.